Hello, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Dr. Charlie Wyckoff, my partner on retina synthesis, and Dr. Harry Flynn, who is the J. Donald M. Gass Distinguished Chair in Ophthalmology at the Bascom Palmer Eye Institute. Harry, welcome to Retina Synthesis.
Carmen, thank you. It's an honor and privilege to be here with you, and it's great to see two great friends, you and Charlie.
So I'm going to hand it over to Charlie. You can start our discussion. This is an important topic. It's a rare occurrence, but when it happens, you need to be ready.
It's a great way to put it, Carmen. Totally agree. And yeah, Dr. Flynn, so appreciate you coming on here to give us your insights over many years. In preparation for this, I did a quick little PubMed search and I put in Dr. Harry Flynn and I put endophthalmitis and I said, how many papers have been out there? And it was over 260 papers on endophthalmitis. I think at least one every year since like the mid or early 1980s. So, Dr. Flynn, you have done a tremendous amount to educate us and inform the field, protect patients for decades on endophthalmitis, and would just kind of love to begin by getting your sort of high-level view of endophthalmitis, how you got interested in it, and where you think the field is now and where it's come from.
Charlie, that's a good question. In medical school, I did a project with one of my professors who was an infectious disease person, and we started doing anterior chamber taps to look at how often they were culture positive. And then when I was doing my residency, I had a couple of cases and I had to figure out the dose of intravitreal antibiotics. And in fellowship, I did a couple of cases as well. And so when I joined the faculty at Bascom Palmer, they had no one that really wanted those cases. Dr. Richard Forrester reluctantly took some of those cases, but I said I would like all of those cases. So
Hmm.
that was called job security when I took cases that other people did not want.
Hmm. And it sounds like over those years, I mean, if you look at, endophthalmitis, how we think of it today, right? We split it off into many different etiologies, right? We have endogenous, exogenous, after intravitreal injection, after cataract surgery, after vitrectomy, after trauma. And you've published repeatedly on every single one of the categories. And did you come up with that categorization scheme yourself, or was it just experience over the years that led you to see these different types of endophthalmitis? How did that categorization come about?
I remember going to the academy back around 1980, and there were courses at the academy, and they did not break it down by categories. They just talked about endophthalmitis in general. And I and other people said, that's not appropriate because there are different organisms in different types of endophthalmitis, and the
Yeah.
strategy for treatment might be different. Again, this
Hmm.
predated the endophthalmitis vitrectomy study,
Hmm.
but I was influenced by Golem Payman, who was a great leader in the field of endophthalmitis. And he had a strong bias towards performing vitrectomy in these cases. And I fully agreed with him. So, at least in Miami, in those cases, particularly in the 80s and 90s, I did vitrectomy on almost every endophthalmitis case.
Hmm. Get rid of the organism as fast as possible.
Yeah,
And
yes.
and now it sounds like the standard of care for retina specialists is the combination of vancomycin and ceftazidime in acute post-procedure, post-intravitreal injection, post-cataract, for example, endophthalmitis when it's suspected. How did we come to those two antibiotics?
Well, when we started off, it was gentamicin. And gentamicin, of course, had a greater frequency of toxicity. And so we looked for alternatives. And gentamicin was sort of across the board coverage for gram top negative and gram positives.
Hmm.
So in 1986, Steve Flugfelder on our faculty did a lot of work with vancomycin. and clearly vancomycin was better for the gram-positive organisms. And so we started using intravitreal vancomycin. And
Hmm.
we found the safest dose based on animal models as well as human experience that the 1 milligram dose of vancomycin was safe and effective and very little resistance among the gram-positive organisms.
Hmm. Well,
And
you're
then the gram negatives, we again we're using gentamicin. And then in the endophthalmitis vitrectomy study coming along around 1990, that study used amikacin. And we were looking for alternatives because amikacin also has some adverse side effects.
hmm
So ceftazidime was equally effective and had fewer side effects. So that's kind of the evolution of where we stand today with coverage of bacterial infections.
Well, it's interesting how that work really defined the standard of care that still exists today. And then layered on that, I'm going to ask you a question about steroids, right? There's, the use of dexamethasone intravitreally. Is that
Yes.
how did that come about, and where do you see that role now?
Well, I have a bias towards using dexamethasone for endophthalmitis because part of the battle, if not the major part, is inflammation. So you can kill the organisms, but still you have toxins created
Hmm.
by the bacteria, and those toxins affect the retina. So
Hmm.
my bias, again, influenced by Golem Payman, who used steroids in almost all of his cases. And again, I agreed with him and had a lot of experience in the 80s and 90s using dexamethasone routinely in suspected post-procedure bacterial endophthalmitis.
Hmm. And then diving into specifically this topic of post intravitreal endophthalmitis with what Carmen led with. All of us as retina specialists perform a lot of intravitreal injections nowadays for patients to help them see better, improve their vision, stabilize their vision. And it's a feared complication that we're all aware of as a possibility. Where are we with the risk of post intravitreal injection endophthalmitis and diagnosis, management, prognosis? Where is that field nowadays?
Well, I think first of all, injections are the most frequent procedure in ophthalmology. That's
Mm,
according to the American Academy of Ophthalmology.
mm-hmm,
So, as such, you can expect that there's going to be a certain occurrence of endophthalmitis. As you mentioned, it's relatively less common compared to cataract surgery or particularly glaucoma surgery with filtering surgery or with tubes. That
mm-hmm,
might be the most common procedure associated with endophthalmitis.
mm-hmm,
And corneal transplant or DSEK procedures are also relatively more common, as you would predict, because the needle penetration of the eye is a small opening and
mm-hmm,
it's relatively sterile. The surface of the conjunctiva is readily prepped with povidone iodine so
mm-hmm,
that you would predict that the rates would be much less.
mm-hmm.
So
So
now
what?
you can read different articles to find different procedures, but in general, it's less than 1 in 10,000
Mm-hmm,
injections for an infection.
mm-hmm,
But again, we see outbreaks when, for example, the nurse or the physician prepares the medication not in a pre-filled syringe, but in a draw the medication up. And
mm-hmm,
it's been shown in multiple studies, in Irish registry studies and in various medical centers that the pre-filled syringes have a lower rate of endophthalmitis compared to the ones that are drawn up by the physician or the pharmacist for
mm-hmm,
preparation.
mm-hmm. And you've also written a lot about, you brought up povidone iodine. You've written a lot about about the importance of sterilizing the ocular surface with povidone iodine. Tell us about some of that work that you've done.
Well, we looked at a number of issues. One is how long should you leave it in place? I think the general consensus is if you can leave it for 30 seconds, that's plenty of time for sterilizing the surface of the globe.
Mm-hmm.
Most people have their assistant or their nurse prepare the surface of the eye with a povidone swab that we
Mm-hmm.
treat the lashes and lid margins with a swab of povidone iodine.
Mm-hmm.
And then immediately prior to the needle penetration for the injection, we put a drop of povidone iodine 5%. And what I do is I discuss with the patient and said, now you're going to hold real steady. I'd like you to look to the opposite side
Mm-hmm.
and you will not feel pain, but you'll feel some pressure
Mm-hmm.
and then administer the medication. And immediately after that, we use some saline to irrigate the surface to wash the povidone iodine off the top, off the cornea and cul-de-sacs, because leaving it in place can cause a lot of irritation and pain for the patient, even more so than the injection.
Mm-hmm. Yeah, it seems like a lot of retina specialists do deal quite a bit with that post-injection irritation that patients get,
Yes,
probably related to that povidone iodine. And
yes,
then the question comes up about allergy, right? Because a patient will have that irritation and they might come back and say, "Well, I'm allergic to povidone iodine." And I know that you've studied that in particular, that concern about
yes.
allergy.
Actually, you and I wrote a paper about that, that povidone iodine itself does not cause allergy, but that term is used often for people
Hmm.
that have irritation after the procedure. And I think it's more of a toxic effect on the surface rather
Hmm.
than an allergy. So
Yeah.
that's why it's important to irrigate the excess povidone iodine off of the surface of the eye.
Hmm.
Would you like to comment, Charlie, on allergy and povidone iodine? Because you and I said it doesn't really exist. It,
Yeah, all very good comments, Dr. Flynn. I still agree with our stance that povidone iodine is a critical component of prophylaxis and prevention of an intravitreal associated infection. You know, some patients are extremely irritated by it, and I agree with the concept of rinsing out afterward. Sometimes topical non-steroidal anti-inflammatory drops after the procedure can help sort of decrease any local topical inflammation. And then, you know, related to that, there is the use of chlorhexidine. So in some situations, some physicians now are using aqueous-based chlorhexidine, which does not seem to have the corneal toxicity that historically was concerned for some forms of chlorhexidine. What do you think about the potential use of chlorhexidine with or without povidone iodine?
well, there's been a controversy about that question for years.
Mm-hmm.
I think chlorhexidine works very well,
Mm-hmm.
and yet most of us don't really have access to chlorhexidine.
Right.
It's used often in other specialty services for
Yeah.
general surgery and orthopedic surgery, but we don't use it in ophthalmology as much.
Yeah.
So all I can say is either one is okay, but we have more experience with povidone iodine. So there may be certain patients who object to receiving povidone iodine, and
Mm-hmm.
chlorhexidine is an excellent alternative.
Mm-hmm. All good points. And then so step us through the next phase, which is in the unfortunate situations where endophthalmitis does develop. You've written a lot about subsequent management and prognosis and risk of things like retinal detachment. What's your overall thought about prognosis for these eyes that do develop endophthalmitis after an injection?
Well, I think it's to a certain extent organism dependent.
Mm-hmm.
So if you get a strep organism or a gram-negative like Pseudomonas, those certainly have a poor prognosis. By contrast, if you have a staph epi or even certain staph aureus, they have a better prognosis and they respond again with early management very well to have a favorable outcome. We had a series of patients with strep contamination of Avastin,
Right.
and we had 12 cases of endophthalmitis occurring from one compounding pharmacy occurring over one weekend.
Right.
And so this was a disaster. And in that setting, 11 out of 12 patients had severe loss of vision because of strep.
Yeah.
By contrast, most of our cases, more than half, are either staph epi or staph aureus. And
Yeah.
those tend to respond pretty well with a favorable visual outcome.
I remember that terrible outbreak that you guys managed. I think you wrote that paper maybe with Roger Goldberg or some other member
That's
of the
correct. We
faculty.
called it the Dirty Dozen because that was a very, very frustrating process.
Yeah. Yeah. Well, I'm glad the patients had you to manage them. Dr. Puliafito, Carmen, any questions,
Well,
comments?
in your paper, one of your papers, you said that 50% of eyes with endophthalmitis aren't don't have an organism cultured. Can you comment on that?
Yeah, I think we're blessed here at Bascom Palmer to have a lab that's open pretty much around the clock so that we will do a tap and then take the specimen immediately to the micro lab and culture it. So that's one benefit here that many private practices or satellite offices don't have for early and appropriate specimen management.
Mm-hmm.
We like to do that. It helps with the prognosis. It helps with management during the recovery phase because it's always a dilemma of when to re-inject if necessary.
Mm-hmm.
So you look at the whole patient, what is the pain level before and afterwards? What is the fibrin in the anterior chamber or the size of the hypopyon or the visual function, even if it's count fingers? Does the patient state, I'm seeing better, I'm seeing clearer now than I did after the injection? All of these factors help you to decide whether you need to do another injection or not.
Yeah, you taught me that pain sign a long time ago, and that's been valuable for years for me. A lot of times the pain will go away very quickly for these patients once you treat it, but if it lingers and persists, those are the patients that I often find benefit in a repeat antibiotic treatment.
Right. Again, I will make a comment and credit Golan Payman for influencing me quite a bit.
Mm-hmm.
Golan Payman used to say always that he would do his tap and inject in the afternoon or the evening, but
Mm-hmm.
not do vitrectomy on the same day. And then he would evaluate the patient the next day. If the pain was better, if the clinical signs were better in terms of hypopyon, fibrin, patient's vision, then he would not do a vitrectomy. But if they
Mm-hmm.
were the same or worse, then he'd start thinking vitrectomy on the next day.
Mm-hmm.
What about eyes that have non-infectious inflammation? What do those eyes look like, and how do we differentiate those from eyes with infectious endophthalmitis?
Well, I think number one, those eyes usually do not have a hypopyon, and usually they don't have the degree of fibrin that you see with infectious cases. So otherwise, it's hard to tell the difference because they may have pain, they may have cloudy media, vitritis, and you may not be able to see fundus details. But I certainly, in those type of cases, I would tend to follow them and not do a vitrectomy urgently. I would still do a tap and inject.
Hmm. And what antibiotics are we using for these cases?
For presumed bacterial endophthalmitis, we use vancomycin 1 milligram, and we use ceftazidime 2.25 milligrams. We usually have it prepared by our pharmacy. In the old days, I used to prepare it myself, and I would draw it up in a tuberculin syringe and transfer syringes, and those days are gone. The pharmacy prepares it for us, and they leave it in a refrigerator, and we uh, have it available, so we go up and take it out and use it. Now, even on the weekends, they prepare enough syringes that we have it. So if a patient comes in on Saturday night or Sunday morning, we've got it ready to go.
So,
Mhm.
Charlie, in private practice, what's the protocol for fabrication of antibiotics?
Yeah, we get them from compounding pharmacies. So we have them pre-made up and they have an expiration date and we buy new drugs if they run out internally. So we have them available to treat people 24 hours a day, any day. Because the concept that we go by clinically is if this is the, one of few things on call that you really don't want to miss, and you want to be available to treat them as soon as signs and symptoms present. And so we often treat these patients after hours on the weekend whenever necessary. And in most cases, we're starting with an intravitreal injection of vancomycin, ceftazidime with dexamethasone. I'd say all three in many cases, unless there's a clinical concern for the possibility of fungus, and then we would often hold the dexamethasone, but that's unusual. Usually in an acute presentation, you're expecting bacteria, and we also use dexamethasone. And then if patients are getting worse or not responding, then we think about a vitrectomy. But in the vast majority of cases, we're starting with intravitreal injections because we can get it into the eye so efficiently.
I agree, Charlie. I think the value of having those syringes drawn up and ready for use is terrific because struggling to measure aliquots of uh, zero point 0.1 cc's and changing syringes and changing needles, it's a little stressful for all of us.
Yeah, want to make sure you're ready.
So, topical antibiotics and endophthalmitis.
I don't think it makes a difference. We don't use topical antibiotics before or after injections. In the old days, we did that back in I would say 10 years ago, but we've stopped. We monitor our cases by the Infection Control Committee. Any cases that have suspected post-procedure endophthalmitis are required to be uh, reported and evaluated by the Infection Control Committee. So that's how we monitor the situation, but we do not use post-procedural topical antibiotics, nor do we use them before the injection. We only use the povidone iodine.
Mhm. And sometimes people might use oral antibiotics concurrently with an injection of vancomycin ceftazidime. For example, ciprofloxacin, because the fluoroquinolones can penetrate the ocular, the intraocular space. What do you think about oral antibiotics, Dr. Flynn?
I'm not real high on that. The problem with the fluoroquinolones is they don't really have a good uh, uh, percentage of coverage for the gram positives.
Yeah.
And so I'm not sure that it does much in the way of value for the procedure. So
Hmm.
we generally don't use them.
Hmm. Well, all great input, Dr. Flynn. Super appreciate your comments. Any last thoughts or topics you'd like to cover related to endophthalmitis?
Well, we have a paper we're trying to get published. So if you review it, please give it a good grade. We looked at our last 5 years worth of uh, 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 cases, and we did last year we did 27,000 injections, and we had one endophthalmitis case.
Wow.
I have to put on my reading glasses to be able to read all the other numbers, but the most we've had in one year was four. 4 out of about roughly 25,000. That's between 2021 and the present date. So
Hmm.
it's a relatively rare event, but
Hmm.
almost all of them are gram-positive organisms. So
Hmm.
we're not seeing the Pseudomonas serratia organisms that we often see with cataract surgery.
Hmm.
That's the good news. These patients have pre-existing, often macular degeneration or diabetic retinopathy. So uh, we kind of worry that those are the patients that we're treating most often, and they're the people that may be more susceptible to endophthalmitis.
Right.
But these numbers speak for themselves that it's a rare procedure, a rare occurrence of endophthalmitis after injections.
Yeah.
And there's no predilection for one kind of anti-VEGF agent or bispecific agent, correct?
That's correct. So we looked at all the different agents, including ranibizumab, bevacizumab, et cetera, including the newer medications for diabetic retinopathy and macular degeneration, and there was no difference in rates of infection. In fact, the rates of infection are going down. As I said last year, 1 in 27,000.
Yeah. Yeah. That doesn't even an exceptionally low rate compared to the literature. Well done, Dr. Flynn. You've got a good protocol going.
Well,
Well,
thank you.
thank you so much, Harry, for your participation in retina synthesis. This was really a very valuable review that every practitioner will find valuable.
Thank you, Carmen. Thank you, Charlie. I look forward to seeing you in the future.
Thank you. Thanks, Dr. Flynn.